Now let's take a look at intellectual disability. Just a word on preferred language. Intellectual disability is the preferred way of describing a cognitive disability. It's still acceptable to describe an individual as having mental retardation, but really now the preferred way of describing that is intellectual disability, and that's the terminology we'll be using. The definition of an intellectual disability is limitations in cognitive functioning and adaptive behaviors. Cognitive function is usually measured by an IQ test, and performance on an IQ test below a certain score is often used to diagnose intellectual disability. Generally, the general rule is 2 standard deviations below the mean is what would be considered to be an intellectual disability, 2 to 2.5 standard deviations. And that's usually how they classify that, but it will vary from test to test. Adaptive skills are also impacted, and adaptive skills are those skills that allow us to function independently. They include communication, social skills, and problem-solving skills, as well as activities of daily living such as cooking, dressing, and those sorts of things. The third thing about intellectual disability is that the onset occurs before the age of 18. Anything impacting cognitive function or adaptive skills after the age of 18 will not be considered intellectual disability, and it will fall under some other sort of disorder. Fragile X syndrome is the most common cause of inherited intellectual disability. It's caused by a change in the gene called FMR1 on the X chromosome, and it's also the most common known genetic cause of autism spectrum disorder. It occurs on the X chromosome, and it's found in both males and females. However, because males only have one X chromosome, they often experience symptoms more severely than females do. Females who have Fragile X syndrome can generally have milder symptoms. Other symptoms of Fragile X syndrome include hand biting and flapping. There will be overall motor delays, including delayed rolling, crawling, and walking. Hyperactivity is a symptom. The tendency to avoid eye contact, so you can see some overlap already with autism spectrum disorder. And then there are physical symptoms, and some of them will be present at birth, and others don't appear until after the onset of puberty. And some of those physical symptoms would be flat feet, large body size, large forehead or ears with a prominent jaw, long face, and soft skin. This video shows some individuals with Fragile X syndrome, so you can see some of the things that we just discussed in the last slide.
You find out the diagnosis, and there is no time to pull the covers over your head. And I clearly know my life is going to be very different than when I anticipated it to be.
I never heard of Fragile X until my sister, she has 3 boys, and 2 of them have Fragile X syndrome. If my sister's a carrier, I could be a carrier.
We know now that about 1/3 of all children with Fragile X syndrome will also have autism.
I know in Mexico a lot of kids are just kind of hidden away. It's not very often that you see a family who has a disabled child out in public.
Garrett at this stage I don't think knows that he's any different. But I don't think that will last. I think once he gets into school and gets a certain age and starts to develop more cognitively, he'll know that he's terribly different. And that will break my heart.
I wanted him to be normal. And if I have any regrets, is that I did not let myself love him at that moment. Just say, I love you just the way you are. And I hope he forgives me. Forever thinking I wanted him to be different.
So you could see some of the behaviors we talked about, but you can also see the the family's responses to their children too, which was kind of nice about that video. Down syndrome is another specific syndrome in which intellectual disability is one of the main characteristics. Intellectual disability in Down syndrome is usually mild to moderate, and it has a known etiology in that it is caused by a full or partial extra 21st chromosome. Other characteristics of Down syndrome include short stature, round face with almond-shaped eyes, greater incidence of certain health issues. There are certain health problems that people with Down syndrome experience more frequently than those in the general population, and those include cardiac problems. Often children with Down syndrome will have had one or more cardiac surgeries, hearing difficulties, and if there are hearing difficulties, then this will impact communication as well as the intellectual disability itself. Respiratory issues, thyroid conditions, childhood leukemia, and Alzheimer's disease are all more common in individuals with Down syndrome. Also, another characteristic is low muscle tone, and this is one of the reasons that physical and occupational therapists would be seeing Down syndrome, but it also impacts speech and feeding as well. Here's another video, and this time it's people with Down syndrome who are talking about themselves. You can listen to their speech and hear how the speech is a little distorted, but the message that they're conveying is most amazing.
No, Down syndrome does not slow me down. It's just what I have in me. I do have Down syndrome, but that's not going to stop me one bit. See, I live on my own. I clean the house. I do exercise. I walk my dog. She's an outside dog. And I got 3 other brothers. They don't treat me special. My name is Mark Joseph Hubler. I'm from Indiana. A Hoosier fan. See? We're more like this different.
My name is Moira Rossi. I am 20 years old. I go to the University of North Florida. I love college. It's the best thing. I'm studying right now career planning and journalism. I'm also taking voice lessons. I want to sing on American Idol and kind of win Simon Cowell over. See, we're more alike than different. My goal is to be successful and be an international sensation.
So those are just a couple of the stories. If you Google "We're More Alike Than Different," there are a whole bunch of them, and just listening to what they have to say is fun, and they're trying to educate the public as to what Down syndrome is and how it impacts people who have it. And the third most common, one of the 3 most common causes of intellectual disability is fetal alcohol syndrome. And fetal alcohol syndrome, of course, is caused by maternal prenatal consumption of alcohol. Other symptoms of fetal alcohol syndrome include behavior issues. Individuals with FAS often have behavior problems that are going to interfere with their ability to function in their daily environments, on top of the intellectual disability. There'll be poor memory retention, so learning new information may be difficult beyond what would be expected for intellectual disability alone. Attention is poor, and there are distinct facial features, including small, narrow eyes, small head, small upper jaw, and smooth upper lip. Let's look at some of the communication characteristics that are associated with intellectual disability. In general, the higher the cognitive function of an individual, the less of an impact there will be on communication abilities. But in intellectual disability, overall delays in language and speech will be present. Down syndrome, like I said, usually is mild to moderate intellectual disability. And most individuals with Down syndrome and mild to moderate intellectual disability will be able to functionally use speech as their primary method of communication. The communicative skills will vary greatly, but in general, these characteristics will be common. Language, like I said, will be delayed. All aspects of language will be delayed, but the desire to communicate is present at a very young age. Down syndrome and intellectual disability it does not have the social implications that something like autism spectrum disorder has. And infants and children with Down syndrome and mild to moderate intellectual disability often have the desire to communicate and interact with those around them. Some areas of language may be more delayed than others. A deviant pattern of language development is not necessarily present. In general, language will follow a typical progression. However, it's slower in development, and it may require more intense teaching and treatment to develop. And then language development typically plateaus sooner than in typically developing children. So individuals with intellectual disability, their development may kind of steadily and slowly chug along, and then it may plateau out sooner than you would expect in a typically developing child. The receptive vocabulary, so what they understand, is greater than their expressive vocabulary, or what they say. And this is actually true for everyone. However, the gap between understanding and expression is generally greater in those with Down syndrome than in the general population. But vocabulary will be an area of general strength. There will be difficulty in following multiple step directions in individuals with mild to moderate intellectual disability. Individuals may have trouble following a series of directions, especially if those that are presented are only auditory. They may rely on visual cues and watching others around them to determine what to do. Grammar is generally relatively weaker than their vocabulary. There will be shorter sentences, and the sentence structure will be less varied. So you're going to see less compound and less complex sentences, probably less use of passive voice, maybe not as many questions, maybe more statements, just not as much variety in general. And word endings are often left off, so this will impact verb tense as well as possessives and plurals. And then speech intelligibility is often impacted. Because of low muscle tone and weakness in muscles used to produce voice and speech sounds, it may be difficult to understand individuals, and the speech may sound distorted and not clear. Insignificant intellectual disabilities, and this includes individuals who fall in the severe to profound range of intellectual disability. Spoken language may not develop at all, or it may not develop to the extent that it is their primary mode of communication. So you'll see limited verbal language. If verbal language is present, the vocabulary may be very restricted to very simple words that are used over and over and repetitive, and utterance length may be restricted to single words. And then understanding is also greatly impacted. So you'll have difficulty understanding concepts and following anything other than very simple or very routine directions. So what are some of the strategies that we can use? Depending on the level of intellectual disability and the individual's age and developmental stage, verbal communication may be all that is needed to effectively communicate. However, for those with more significant levels of involvement, or for younger clients who are still working to develop spoken language, you may find some of these strategies helpful. Visual cues. Visual cues are going to be very powerful, mainly because visual cues are more permanent, they're more concrete, and the person can actually see what it is that you're asking them to do so that they can process it. So when you're asking someone to do something, you want to model and demonstrate it. Don't just give a direction. Demonstrate what it is that you'd like to be done, and then limit those directions to single steps as much as possible. If you have to use multiple step directions, then our next thing is to use picture schedules for complex tasks. If you have something involving several steps, break the task down into its components and represent each step with an object, a photograph, a picture, or with just words. Once again, you can use those visual cues to offer choices. Individuals with severe or profound intellectual disability may be able to point to indicate a choice even if they do not have the vocabulary to state their choice. I can think of one little guy that I worked with, and I worked with him for many months, and we finally were able to teach him to point. And what we used to teach him to point was gummy bears. And every time he pointed to a gummy bear, he got to eat one. Well, all of a sudden, this child was pointing at everything. We were walking down the hall, and he pointed to get a drink. We were sitting at the lunch table, and he started pointing to the food on his plate that he wanted to eat. So just by teaching that one simple gesture, he was able to use visual cues at that point and indicate what he wanted. And it was mostly at the object level, but we started to work some at the photo level too. So offering choices for individuals with severe to profound disabilities by using visual cues can be a powerful way for them to communicate. Sign language is another way that we could facilitate understanding as well as a way of expressing wants and needs. And when combined with spoken language, the use of signs, once again, will often help with learning spoken language. But for you, you're not really necessarily trying to teach that spoken language. You're really just trying, the signs can really facilitate a way for you to communicate with your client. So learning the sign for help, especially, and for preferred activities that you do in your therapy sessions will be really helpful. And finally, use the environment as much as possible. If you're talking about something around you, point to that object. If you are, if you're talking about the weather, you can move to the window and look out. If you're talking about setting up something over the telephone, then point to the telephone. If you are talking about using the computer, then you can point to that. So use what's around you to help facilitate understanding. Another thing you're going to do, once again, is modify verbal language. So you'll see some of these strategies are going to pop up. Actually, almost all of them are going to pop up in each thing we talk about. But the reason that we use these strategies is going to be a little different for each time. One of the things that we want to do is allow extra response time. You want to allow time to process what you've said and formulate a response. It's always tempting to jump in and help because waiting feels awkward to us, but waiting is really powerful. It gives the person the opportunity to say what they want to say. The other thing we want to do is check frequently for comprehension. Don't just assume that because your client is nodding and going, that they're actually understanding what you're saying. A lot of individuals with intellectual disability who have no other concomitant disorders such as autism spectrum disorder don't have any social issues, so they will be socially with it enough to recognize that they should be saying something and should be doing something, and they'll be doing that nodding. Also, you want to think about the difficulty continuum when asking questions. Open-ended WH questions require the most processing time, and they present a greater linguistic challenge than multiple choice or yes or no questions. So you want to balance checking for comprehension with making sure that you're not overloading your client. Proximity is also important. Always try and be within a few feet of your communication and partner and try to eliminate any distractions. And then another thing you want to do is repeat or rephrase what you think you've heard. Because the individuals may be hard to understand, if you repeat back what you've heard or rephrase what you think was meant, then you're allowing your communication partner to either confirm that what you think is right, or you're giving them the opportunity to try again and to correct you. So that you know that they're actually getting their point across and they know that as well. And then technology. Because of the visual nature of technology, many people with intellectual disability will effectively use apps or communication devices to communicate their wants and needs.